4, 3, 2, 1. We are live now.
Good evening, everyone. We welcome you all to the second batch of the Arthroplasty Fellowship, the virtual online Arthroplasty Fellowship brought to you by Dr. Gurva Reddy and the Sunshine Hospital team. To introduce the program, I would hand over to Dr. Gurva Reddy.
Good evening, everyone. It's a pleasure and privilege to welcome you all for the Arthroplasty Virtual Fellowship 2. The first fellowship was a resounding success with almost 100 people got benefited. And the beauty is it was a very, very interactive session. And I should thank all my faculty that they really put all their efforts. They have not taken it as another thing. They have put their heart into that and they have started answering the questions of the fellows even after the fellowship is finished. I have seen that flavor and I really congratulate all my faculty, all of them for putting that heart. Because teaching is an active process. Unless the teacher is committed, there is never going to be a complete teaching process. And I'm very happy that Sunshine has got that flavor and that DNA and that passion to teach. It is not just another thing. We just wanted to finish 1 hour class and go home. No, we are here to serve all the people as deep as we can and as much as we can. So fellows, be active. You all paid money. It is not a charity. You all paid money to get benefited. So definitely take the benefit. I congratulate Ashok and Neeraj. I won't get tired. These two guys have taken and have brought dramatic changes in the learning process of orthopedics. Hats off to you guys. Many people are learning properly and many people are learning very, very, very deeply thanks to you guys both. And so I request all the fellows to be interactive. Ask whatever the silly questions. Don't worry. We all went through the same path and we will be very happy to answer you and show you extra videos, extra answers. There is nothing like only we have to tell in this framework. Whatever the questions you ask, we are happy to answer that in the next 12 weeks. With the brief introduction, I'll introduce my faculty. In fact, this second season, we got 3 more faculty added. Am I right? 3 or 4? Ratnagar?
Sir, yes, sir. 3 more, sir.
3 more. That is Rajiv.
Tarun and
Rajiv.
Sandeep.
And
Yes,
Pranav and Sandeep. All 3 are the young guys, but they're all very, very learned here in Sunshine. And they will again take mantle to the next level. So my senior faculty is Dr. Vivian Prasad, Dr. Suhas, Dr. Chiranjeevi, Dr. Ratnakar, Dr. Kishore, Dr. Adarsh, Dr. Kushal, and anybody I missed?
Praharsha.
Dr. Praharsha. Good. So thank you so much, all the guys. So with that, I'll give it to Ratnakar to take it to the next level. Yeah. Ratnakar.
Good evening, everyone. I welcome all the fellows for this second session. So we have planned some agenda for this next 12 weeks. I'll just like to share the agenda. Can you see this, sir?
Yes.
Yes, we can see it.
Yeah.
Just zoom it out a bit. I think it's, or it's a slideshow kind of thing. Okay, fine. Go ahead.
Yeah. So, so the time is every Fridays, 8 p.m. to 9:30 p.m. We have almost scheduled for 10 weeks. There are certain more topics which will be added based on the interest and requisitions from the fellows. In the week 1, so we thought we will have an active interaction and introduction about each other. At the same time, we would like to know what is the requirement of the fellows from this virtual fellowship. Because there are certain people who are very new to orthoplasty. There are people who have been doing orthoplasty. So we have to tighten and make it fruitful to each and everyone who has opted for this fellowship. At the same time, we will be having a clinical examination by Dr. Tarun, preoperative optimization by Dr. Rajiv, and preoperative X-ray reading by Dr. Sandeep this week. In the second week, we have post-operative X-ray assessment. And Dr. Chiranjeevi will be speaking on how do I choose my implants, various options like CRPS, the referencing systems, when to use rods, and the tips and tricks in selecting particular implant for a particular case. And Dr. Mrinal will be speaking on approaches and their practical significances. So each of these sessions we are trying to add certain videos so that not to restrict only to a theoretical part. In the week 3, Dr. Kishore will be describing about the surgical technique in TKR, and the 10 successful commandments by Dr. Guruvara Reddy sir himself will be addressing to the fellows on this topic. In the week 4, everything about the varus, right from the very mild varus to the complex varus deformities. Week 5, Dr. Suhas and Dr. Vivian sir will be taking us about valgus knees. In the week 6, I will be speaking on flexion deformities and recurvatum in TKR. And in the week 7, Dr. Adesh will be speaking on anteromedial osteoarthritis and how to manage the intraoperative complications by Dr. Prahasha. And again, I will be speaking on bone defects in primary TKR. Then in the week 8, we will be speaking about the post-operative protocols by Dr. Tarun, which includes all the protocols like antibiotics, DVT, tranexamic acid, pain protocols, cocktail infiltrations. And Dr. Sandeep will be speaking on rehab after the TKR. And finally, we will be having an overall overview of all the complications where all of us will be participating. Please note that each and every week, all the faculty will be open for discussions. And then last week, we will be speaking on recent advancements like robotics and alignments in TKR by Dr. Suhas. And Dr. Kushal will be taking to a short journey about the extraarticular deformities in osteoarthritis. We have additional topics like stiffening in TKR, patellofemoral complications, which will be reserved as on required. And every week, we have decided that we are going to give 15 minutes buffer, which will be open for discussion from all the people, all the fellows. We request each and every participant to come forward with some of their cases, if they are planning in the next weeks or already they have burned their hands in any of the cases. So they can openly put those short presentations, and the faculty will be guiding them what went wrong and what they should, they will be suggesting how to take up these cases. In case there are no special cases or challenging cases from the fellows, we would like to show any challenging cases from our side. So 15 minutes buffer is given every week. I request everyone to share me in my personal window if they have any personal cases to discuss in the group. So this is in short, the agenda for the next 10 to 12 weeks. If anything else you require, please let us know well in advance so that we can prepare. We can take certain videos if needed, and then we can display here on the class.
Yeah. Thank you, Ratnagar. Can you hear me?
Yes, sir, we can. Sir.
Yeah. I request all the fellows to be very active and not to spend this 1 hour taking care of the clinic or playing with the children and putting this thing into the sideline, because it's your loss, not our loss. So we are all trying, we are giving our best to you guys. So if you are actively involved and if you show your enthusiasm, the learning process will be good. So that's what. So I request all the fellows to keep your cameras open, to keep your videos open, so that we will scan through, and if anybody is dozing, we can wake them up. So that is the plan it is. Okay. So, right. Ashok, how many people are registered?
So 120.
120, right. Okay, I think so, right.
I think we have some people from outside of India also. I don't know.
Yes,
like.
we have. We have people from even France.
France?
Yeah.
Oh boy, you are international, Ashok. Wonderful. Right, good. So it's now without further ado, Ratnagar. So we will start. And Ashok and Neeraj, any thoughts from you?
I think like you said, the first fellowship was really, really helpful.
Yeah.
And it is a two-way effort. So as much effort put by faculty, I think the first batch exploited it good, but it could have been better. So we'll request the second batch to be interactive as much as possible especially in the live Zoom sessions and also on the WhatsApp chat. So they can ask any queries or any case that they are stuck with. So use this opportunity to, I think it's a privilege to have mentorship with Dr. Guruva Reddy and a team of 10 experts. This is like a very, very unique opportunity for all of you. And if you create that bond between yourself and all these mentors, you'll be benefited for life. So take this opportunity, create the bond, learn as much as possible, and keep this time as priority every week for yourself.
Yeah, exactly. And another offer I'm giving all the 120 guys, you can ring us and come and stay with us as an observer anytime during the fellowship or after the fellowship. You're all open. Sunshine is open for teaching. Come down, scrub with us. Suppose if you stay with us for 2-3 days, you will be scrubbing for 50 cases at least. So you no issues at all. So that offer is open for all the fellows. Ashok, I'm giving that offer.
Thank you very much, sir. That's such a
Thank
kind
you so
offer.
much.
Yeah. Okay. So guys, it's up to you to make use of that. As Ashok rightly said, to get a team like us who are involved in 4,000 surgeries per annum, such a high volume center, to spend time with you, for you to get answers from you, it's a very unique opportunity. Make use of that opportunity, my friends. So, right. So, Ratnagar,
Sir,
can we start?
yeah. 2 minutes, sir. I request
No.
every fellows to go through each and every message in the WhatsApp groups. Please don't ask same questions again and again, because already we have experienced this in the previous batch. Already one person is asking, we have answered these questions again. The same questions are being repeated. So this you will lose the opportunity in getting new questions by doing so. And at the same time, please keep your audios completely muted when the speaking, when some lectures are going on.
Fellows, think that this WhatsApp group is from your girlfriend. So you will see every minute your girlfriend's messages and leave the heart emojis and all that. Like that same way, you treat this WhatsApp group like your girlfriend. Then you will get all the information needed.
And before we start, sir, I just would like to know, can you please lift your hand who are very new to orthoplasty?
Right. Yeah. George, Raghunathan. Yeah, there are some people. Yeah. And what I suggest is, we will start as though it's a basic, that you don't know anything. So for some guys who are already into the practice, this might look a very basic, but let it be like that. The best way to teach is to think that all the audience do not know anything and start from the basic. So let us do that. Again, let us revisit the basics. So that's a very important point. Okay. And again, feel free to ask the questions. If you want any videos, suppose you have not understood a principle, you ask for a video, we will make a video for you. That's what I'm saying. Okay, if it is not in our repository, we'll make a video and present it in the next week. So that's what it is. Right, guys? Right.
Yeah.
And keep the audio muted, but video on, so that it will be very nicely interactive session. Sometimes I'll ask the questions also to individual. I can see Yogesh Narkhade in front of me. Yogesh, how are you?
I'm good, sir.
Where are you from?
I'm from Pune, sir.
Pune, wonderful. Okay,
Pune.
very good. The birthplace of my professional career. I was trained from Sancheti. My son was trained from Sancheti. Wonderful.
Yeah,
Good.
I know, sir.
So, right, let us see. Aman Sharaf, where are you from?
I am from Gwalior, sir, Madhya Pradesh.
Gwalior. Wonderful. I'll say next guy to you, Sudan. Where are you from? Sudan, unmute. Sudan, unmute yourself. No, you can't. Okay, fine. Right. So let's go. Ratnagar,
Yes, sir.
you ready?
Sir, actually, there is a small change in plan because Tarun is yet to reach his home, sir. So we'll start with Dr. Rajiv, sir.
Yeah,
About
sure.
pre-operative optimization before TKR, sir.
Yeah.
Rajiv, you
Right.
here?
Yes, sir.
And again, let me
Yes.
tell you, fellows, total knee replacement is no rocket science. Anybody can do it. If anybody says that you can't do it, only I can do it, don't believe him. The knee replacement is one of the easiest operations in orthopedics. It is nothing but a glorified carpentry. But you should get basics right. As simple as that. Okay. So let's go. and make 120 guys the top of the joint replacement surgery. After you, Rajiv.
I
Yes, sir.
request
Good
everyone
evening,
else to mute themselves before Rajiv starts because there's a lot of disturbance. Everyone, please mute yourselves, or I'll just mute all, and Rajiv, you can unmute yourself after that.
Yes, sir.
Yeah, go ahead. Unmute yourself, Rajiv.
Rajiv?
Rajiv, unmute yourself.
Yeah, I have done so. Hello.
Yeah, Rajiv, now we can hear you, Rajiv.
Yeah. Good evening, everyone. Topic for today is preoperative optimization in total knee arthroplasty. So, yeah. So coming to the last 15 years in the joint replacement, there is not much innovation in the implant design or technique, but the tremendous work has been done in the perioperative care of the patients, enabling rapid recovery and mobilization after the surgery. Total knee replacement has become one of the most successful surgeries in the field of orthopedics. When you come to the projected volume in the US, from the Journal of Bone and Joint Surgery, primary total joint arthroplasty from 2014 to 2030 data, if you take, there has been increase to grow up to 85% for the knee to 1.26 million procedures by 2030. But whereas for total hip, it's about to grow 71% more by 2030. So that means you can see that there is a tremendous increase in the total joint replacements, both in the knee and the hip, whereas knee is always forward. Next, coming to the length of stay, which is always discussed since past 20 years. So if you take from 1997, the length of the stay for the total knee replacement or THA was around 16 days. This is according to the National Health Survey of UK. But whereas in 2014, it has come down to 5 days. And there was also a study in the Journal of Arthroplasty in 2015, US, the 74.8% had a hospital length of stay of 3 days or less. Currently, in our hospital, Sunshine Bone and Joint Institute, for a single TKR, we give it for 2 days or max 3 days. But whereas bilateral TKR, 3 or 4 days is a length of stay. So there you can see there is a drastic fall in the length of the stay. The patient's outcomes are much better within 3 days with the post-operative rehabilitation. Next, coming to the most thought topic for every patient was a dissatisfaction. There was only a 20% according to the literature, but to tell the fact, actually, in our practice, what we see in Sunshine and everything, it is only around 5 to 6%, max is 8%. It is one of the most successful procedures, but literatures keep varying from 14 to 20%. So dissatisfied maximum, they mostly depend on two things. One is the depression and the anxiety, which are always highly prevalent psychiatric disorders. Next, coming to successful TKA is always the best thing for every surgeon. You should always write surgery to the right patient. The preoperative counseling is a must. Preoperative optimization, modificable and non-modificable risk factors to be optimized. Surgical expertise to be thing, and the post-operative care is the most thing. Yes, sir.
Guys, there is a lot of disturbance. There's someone in the car and someone seeing the patients. Please turn off your audios.
Please ask the OrthoTV to enable you as a co-host so that you can unmute all together when the faculty sir is speaking.
Yeah, I think I can continue now.
Yeah, Raju, please.
Yeah. So this is the roadmap for the joint replacement surgery at our Sunshine Bone and Joint Institute. So our boss, Dr. Ravi Guruvareddy, sees the patient after screening is done by the fellows. Then whether it is an andromedial osteoarthritis, whether it is a unicompartmental or bicompartmental, the sir decides it. And can someone please mute it? Yeah. So sir sees and sir decides the patients. Then once the counseling is done, patient is planned for the total profile, which includes all the complete bed picture and everything. Then the cardiology fitness, which included ECG, 2D echo. But in case if there are any ECG changes, the patient would be transferred to the cardiology till he gets the fitness. So based on that, we decide this thing. Some patients go for cath lab either with angio and everything. Then once they're fit enough, they come back for the pre-anesthetic evaluation done by the anesthetist. Then after that, they decide which they opt to go for. Then we decide the date of the surgery, then the implant of their choice, then the admission. Admission is usually done on the day of the surgery. So in case if you're operating at our morning 6 a.m., we admit the patient at 5 a.m. and the stay in the hospital is only for 3 to 4 days. And surgery, then on the first post-operative day 0, they stay in the SICU for 24 hours. Then the next 2 to 3 days, and the post-operative rehabilitation is done for a period of 1 month. So this is our roadmap for joint replacement surgeries, and this has been followed since past almost like I can say 14 years in the sunshine. Next, so right surgery to the right patient. So every surgeon should know this very importantly. If a patient comes to you with anteromedial osteoarthritis, you should plan for unicondyle error. You should never go for a TKR just because he come to you for a medial arthritis pain. Yeah, so this is most important, and choosing the right patient is also most important. Every patient should fit into your criteria if you're planning to do an AMOI. Then next, coming to preoperative counseling, which is the most important for any patient and attender, what you have to do. So things include is patient education, which includes surgery, what implant are you trying to use, then what company, then course in the hospital, and the discharge and the post-operative protocol. And second thing, what you need to assess is the mental state assessment. So a lot of patients are into depression and anxiety, some patients, so which are always highly prevalent. So don't worry about that. The next is managing patient expectations, then pain management. First, coming to preoperative counseling. So preoperative education means there is group counseling. So you group counsel the patient and the attenders about the surgery, about the procedure, about the post-operative outcomes, about the everything. Then the clinical pathway, as I already showed you, our roadmap for the joint replacement surgery, including the pre-op till the surgery happens. Then digital education knee models. So always have the anatomical knee models and show them exactly what you're trying to tell them, like where the arthritis is, how the knee has become, and what are you planning to do, and everything. And you can show some videos to them, how a varus knee is corrected, how the post-operative patient is walking, and all those. So once all this is done, then the date of surgery and the anesthetic checkup is done and the date is planned. The next, coming to the mental state assessment, as I already told you, depression and anxiety preoperatively is associated with the poor post-operative function and less satisfaction, because depression is increased. Depression is always associated with risk of persistent pain, discomfort, and complications. So these two should be taken care of, and counseling should be done. The next, coming to expectations. Every patient has a lot of expectations. After that, they want to dance, they want to fly, everything. But there's an article published where this is preoperative expectations are always associated with postoperative dissatisfaction. That is also only, I say, 5 to 6% in our institute. And as the literature says, it's 15%. Yeah. The next, expectations are always correlated with satisfaction. So Tilbury et al. Has done a study in 2016. He reported that in all the dissatisfied patients, there are always unfulfilled expectations are high. That means the improvement walking ability for long distances, they're being able to kneel down and being able to squat around 40 to 47%. The next, multimodal pain management. Pain is the most common concern of every patient and the attender who comes to you in the OPD who's planning for the total joint replacement. So in our institute, we have a multimodal pain management, which includes a preemptive analgesia that is given on the day before night of the surgery, the neuraxial anesthesia, then adductor canal blocks are given for the pain relief, then intra-articular cocktail, which include a combination of ropivacaine, methylprednisolone, adrenaline, and ketorolac. Then non-narcotic analgesics, celecoxib or anything, then steroids, pregabalin, and antiemetics. So coming to the first, preemptive analgesia. Preemptive analgesia blocks the noxious stimuli before sensitization and minimizes the amplification of pain response to further stimuli. So our preemptive analgesia is a combination of 5 medicines. One is pregabalin, that is a neuropathic pain medicine for 75 milligram. Then Zicel coxibs of 200 milligram, Restil of 0.5 milligram for anxiety. Then dexamethasone of 8 milligram and a Pant-D of 40 milligram. And preoperative bay, that is on the preoperative area, we give a paracetamol 1 gram per oral stat. Okay. Then we plan for the take up for the surgery. Then optimization of the patient for TKR. Okay, so every orthopedic surgeons should use the optimization approach so that it can reduce the post-operative complications and also improve the overall safety of the procedures they perform. It's basically optimization two things. One is you optimize the medical condition, what kind of a disease or drugs, then optimizing physical state, outpatient and home-based exercises. So it's always a better outcomes, happier patients and happier surgeons. The next, coming to the optimization of patient, is there is something called readmission risk assessment tool. So which include the infection is a major risk factor, then smoking, obesity, then cardiovascular diseases. Everything is decided with scoring. So if the score is more than 3 or 4, it is associated with a higher readmission due to infection. So you should always note which patient is high risk. If the patient is obese, or if the patient is having any other chronic infection or anything, or any CKD, anything, you should always see and then optimize that patient and then plan up for the surgery. Next, coming to the risk factors. The most important in the optimization is there are two things: modificable and non-modificable. Non-modificable is always age and their chronic diseases like CKD, chronic heart failure, COPD, then cirrhosis. Modificable risk factors are cardiovascular diseases, then poorly controlled diabetes, opioid, malnutrition, smoking, obesity, and UTI. So there is an article published in the knee surgery and related research. It says, is there any optimal age for total knee arthroplasty? It's a systematic review. But they say 70 to 80 or 85 years is also an optimal age for total knee arthroplasty. You can always encourage that patient for knee replacement and optimize his preoperative conditions and give him a better post-operative outcome. Next, so coming to smoking is one of the modifiable risk factor. So smoking, it reduces blood flow, oxygenation at the surgical site, which delays wound healing. So you should always be careful in the smoking patients. The current smokers had higher 1-year post-operative prosthetic joint infection rates than former smokers, both of which were significantly higher than never smokers. So the overall 30-day surgical complication rate was higher in current smokers at 2.5% compared to 1.4% in non-smokers. So conclusion is basically the tobacco use prior to total joint arthroplasty significantly increases the risk of wound complications and PJI. Next, coming to diabetes. So a lot of confusion about the diabetes, whether when to operate, why can we wait or what. So preoperative hyperglycemia and elevated HbA1c are not likely direct risk factors for PJI, but more likely to be indirect markers of more serious comorbid conditions like CKD and peripheral vascular disease. So diabetes is always an independent risk factor for PJI. HbA1c is less than 7, 6 weeks pre-op is ideal. For those with HbA1c more than 8 to 9%, or if the renal blood glucose levels between 180 to 200 milligram, optimization may be consideration in the preoperative period. Next, coming to anemia. Hemoglobin more than 10 is always taken as cutoff. If the hemoglobin is less than 10, always arrange two units of this thing and plan for a single leg if you are doing it. If it's a bilateral, you should always try to have a hemoglobin of more than 10 with arranged 1 unit. Then hemoglobin less than 8 is never accepted, and preoperative transfusion should be done for a patient for this thing. Then there is also a study in BMJ where they say preoperative iron treatment in anemia patients undergoing elective total hip or knee is also useful. But at the end of the day, transfusion is always the best in case if they are having less than 8, and you have to always find out the cause of the low hemoglobin. Then next is chronic renal failure. Risk of prosthetic joint infection is 22% in hemodialysis patient. If it is a renal transplant, it's 8% risk of PJI. Current evidence suggests that patients with end-stage renal disease, they require hemodialysis fare worse than non-hemodialysis CKD and renal transplant patients. You always need to monitor your creatinine, monitor kidney function, avoid nephrotoxic drugs, and dose adjustment for antibiotics and pain medicines. Next, cardiovascular disorders. All patients will require an ECG, 2D echo, and cardiology assessment, then roll of CAG, then sometimes dobutamine stress echo can be done for fitness, then bridging anticoagulation for post-CAVG or PTCA patients, then pacemaker spacing. So in cardiovascular disease, I would like to tell so a lot of patients would be using tabacospirin or clopilate. So what happens is if it is an clopilate 150 or ecospirin, you always have to wait for 5 days. If it is an ecospirin, just 2 days is enough, 75 milligram. Then next is obesity. The risk of PJ is always high with obesity as BMI increases. So in cases with BMI of 30 to 40, the risk of PJI is only 2.6, but morbidly obesity, it gets increased to 5.2. But super obese patients more than 50 is 12.4%, which we always prefer to go for a bariatric surgery, get done and come back for a total knee arthroplasty so that they'll have a better outcome. So Indian setting, rarely the BMI is more than 40 and is not a contraindication. Then next, coming to malnutrition. Usually see in the blood profile the low serum albumin, which is most common in the usually seen few patients. So obese patients especially. So less than 3.5 gram is an independent risk factors. So usually if it is around 3 is also okay, so that you can give a post-operative albumin correction to them. But if it is less than 2.5 or 2.4, there's a high chance of leading to SSI or cardiac or respiratory complications. So hypoalbuminemia is 3 times more likely to have an indication of sepsis for revision arthroplasty and twice as likely to develop PGI within 30 days of revision for aseptic indications. Then opioid usage. Moderate evidence supports that the use of opioids in total joint arthroplasty to reduce post-operative pain. Opioids should be used cautiously as they may always increase the risk of complications such as respiratory depression and sedation, especially if combined with other central nervous system depressions or used in the elderly. Counseling also should be done regarding the length of recovery in this patient, especially who has opioid usage. Then next, coming to UTI. So a lot of patients, sometimes they turn urinary tract infection when they give culture or anything. So there was a study done by Javed Pervezi. He says that should a urinary tract infection be treated before a total joint? Yes, symptomatic UTI is a risk factor for PJI and should be treated before proceeding for any hip or knee. However, asymptomatic bacteremia is common in patients undergoing total joint arthroplasties and should not be considered as a cause of PJI. In these asymptomatic bacteremia patients, neither preoperative urine culture nor preoperative treatment is necessary before TJA. So in case of any urinary UTI is suspected with the clinical symptoms of burning micturition or anything, you'd always get a urine culture rip done and then check the organism and treat with the appropriate antibiotics for 5 to 7 days and then plan for the total knee replacement. So next, coming to the optimization of the physical state. So I would like to say a thing about exercise. So why is exercise so important for your recovery? That will strengthen so strengthening the muscles is the most important thing in the knee or hip. So strengthening exercise for hip and knee joints will improve the faster recovery and a better outcome. Upper body conditioning exercises reduce muscle soreness and fatigue caused by the use of a walker, crutches, crane, or other aids. A walking exercise program will increase the endurance, flexibility, and the overall strength of the patient. Optimization of physical state. This program includes warming up exercises for the upper and lower limbs, initial stretching exercise for calf, hamstring, quadriceps muscles, then isometric and isotonic strengthening exercises of the quadriceps, hamstring, hip flexors, hip extensors, hip abductors, shoulder flexors, shoulder abductors, and triceps flexors. Each session should be last 30 to 45 minutes, 3 times weekly over a 4-week period immediately prior to surgery. Take-home message. Give realistic expectations to the patient. Prepare the patient through a proper preoperative counseling. That means counsel the patient and the attender and make them they're aware of what you're going to do and what is happening. Then take them through the whole procedure from pre-op preparation to post-operative rehabilitation. And the approach is always with the multimodal pain protocol, because that is a main concern of every patient, pain. So you should always go with the multimodal pain management. Yeah. Thank you.
Next one, Raju.
Yeah, thank you.
We can take a couple of questions if anyone has at this stage.
Yeah.
You can unmute yourself and you can you can ask your questions.
Can I ask a question?
Yeah, sure.
Yeah. For urinary tract infection, because many ladies would not be able to tell whether they are symptomatic or asymptomatic. So it's very difficult to, ask a lady whether there's burning micturition or that. So is that the only criteria, burning micturition or?
Yeah, as per the literature, it is asymptomatic bacteria as there is nothing to do with your TKR. You can go ahead with your TKR. But if it is a symptomatic bacteria, that is your symptoms, any of this increased frequency or urgency or burning micturition, then definitely you should treat your UTI, preferably within cultures, then give them optimal antibiotics, then plan after 5 to 7 days. Asymptomatic bacteria, you need not hold on for your surgery. You can go ahead with surgery.
Yeah, and do you do a USG abdomen for post-void residual urine before surgery?
No. See, again, if the patient is having any prosthetic symptoms, sometimes if these patients will have very increased frequency or some painful frequency, then we will ask our urologist to see then they will take a call about this post-voidal residual volume to be checked or not. Not for all the patients.
As a routine, no,
no.
USG abdomen.
No, we won't.
Yeah, thanks.
Yeah.
And
Rajiv, excellent talk.
Sir.
Nicely backed by
thank you, sir.
papers. That is very
Yes,
important. And I request all the fellows also, because you're all getting into a very specialized branch. So please put focus on the papers and the literature rather than just didactically listening to that. You nicely covered. And preoperative stabilization for patient selection is very important.
One question.
The first 100 knees you select very, very diligently. So don't take a too complex knees. Don't take fixed valgus. Don't take 90 degrees of flexion deformities. Of course, if the patients come to you, you don't need to let them go to somebody else. Call some seniors and let them do the surgery. And you be a ghost surgeon and you learn the tricks of the trade. But don't take too much on the day one, because one complication in the first 100 knees will spoil your reputation. So be careful about that. Yeah.
Is there a need for nasal swab are taken routinely?
Pardon? Is there?
Nasal swab are taken for MRSA?
No need at all. Nasal swab are waste of time. And
is there any?
Yeah.
Sir, dental opinion or any
foot
examination?
No need at all. Dental, we sometimes we involve if there is any dental patient himself say that I got a caries of teeth and all that, but otherwise routine is not needed.
Preoperative MRI spine screening, sir, any usage?
No, yeah, good question. Very good question. That is Manjunath. See, if every knee replacement patient preoperatively in the OPD, you should make them walk. So dynamic manifestation of the gait is important. And let me tell you, however bad the arthritis, the arthritic patient will never fall. At the most, he won't be able to walk. But if the patient says, I keep on falling, then alarm bell should ring. Immediately, you should make them, every patient, you should make them walk. And sometimes the patient walks on a very unsteady, staggering gait. And so that rings alarm bells. That means this guy has got a canal stenosis at a cervical level. So immediately send them to neurologist. I burned fingers 2-3 times in my initial days, and now it's a mandatory. Any guy who fits you unsteadily, because if he's keeping on falling, arthritic patient will never fall. So then immediately refer to neurologist. You don't bother. Let them take MR scan, let them see the jerks, and let them give you an opinion. So time and again, canal stenosis, cervical myelopathy, very important point, because chronic stenosis and cervical cord will become myelomatic, and then don't touch these patients, because your surgical insult on the knee will aggravate the myelopathy as well, and the patient becomes much more disabled, and that is a disaster. As I said, I burned my fingers, so don't do that. So always eliminate the spinal cause for this one. And time and again, you will get patients with both arthritic spine as well as the arthritic knee joints. Then again, talk to the spine surgeon, let them take an MR scan, and then decide which one to go first. Some people take spine first, and some people take the knee first. It depends on these things. But again, it depends on the symptomatology. So discuss with your spine surgeon in front of the patient, and then take
Parkinson cases, sir.
If a patient has come and he has a HbA1c of 8 and he's a chronic smoker, how long should we wait before we can offer him the surgery?
Chronic smoker, basically, you should stop smoking. Of course, smoking has got a bearing in wound healing and the infection.
How long should we wait, sir? How long?
Mainly in the spine than in the knee replacement surgery. So you just ask him to stop perioperatively, and you can take him immediately for the knees. But for spines, they say that we should minimum 4 weeks, you should stop. The second thing, the HbA1c, if it is 8, if he is an outstation patient, involve your diabetic guy and then let him monitor perioperatively. So that's one important point. So any arthroplasty surgeon, whatever the type of town or city you are practicing, get one cardiologist, one diabetologist under your wing. That means you become friends with them and call them for every consultation. That's very important.
Hello. So we We need not send the patient back at HbA1c. We can do a
No need
perioperative
at all. No need at all. If he's outpatient, of course, if he's a same city, and if you're comfortable with him coming back to you, then you can treat him and then get him back to the surgery.
Yes, thank you.
Yeah,
But
just
perioperative
one
monitoring
question.
by a diabetologist is mandated, not by you.
Yes.
Dr. Nitin, if the patient is having very severe knee pains and his gait is badly affected, you can't expect him to do walking and reduce his HbA1c. But
Yes.
what you can do is a proper perioperative insulins and all, so reduce the glycemic, have a glycemic control there. Yeah.
Hello,
Yes.
sir. Hello.
Yeah, Jamin.
Yes, sir. Can we know the medicines that are being used in the multimodal pain management, sir?
Yeah, we will put it in the chat. Ratnagar?
Yeah,
Put
that
the
we have
multimodal
a session on
complete
all
our
those
regime.
things.
Yeah.
Post-operative.
Yeah, and that will happen very well. So, Jamin, the multimodal analgesia starting from preemptive analgesia one night before works wonders. So you got to concentrate on that. Gone those days where you will say that "Arey pain to hota hai bhaiya." Nahi. So pain is one of the main things to attack. Then you will have many more patients to come.
Yes, sir.
Cryotherapy. Post-operatively, buy nice cryotherapy units are there. Even if they cost, buy 2-3 units and every patient put a cryotherapy. It will be very useful for you.
Sir,
Yes,
does
sir.
any upper limit of BMI for the contraindication of knee replacement?
Yeah, in your first 100 cases, your BMI should not be more than, how should I put it?
40, sir.
30.
40.
30.
35 to 40.
30, not more than 30.
30.
Yeah.
Yeah, Dr. Abhay.
Sir, I wanted to ask one question. Is there any evaluation for the osteoporosis? Do we do a DEXA scan or a BMD?
Yeah, good question. Good question. Osteoporosis, you don't need to do DEXA scan, but rheumatoids, and 9 out of 10 times, you will see on the X-ray thin cortical line. So your properly taken X-ray will give you enough weightage, but you should be sensitive to that finding. Number one. Number two, all the rheumatoid knees, and if the osteoporosis is there, I'll tell the patient beforehand that I will rod the tibia and the femur as needed. So that rod should not be a surprise. So rodding of an osteoporotic bone I've been doing for the last 20 years. It gives excellent results. It will anchor the bone very well, because otherwise sometimes osteoporosis, the implant will sink. So that's why rodding of osteoporotic bones is imperative. But tell the patient beforehand, look, bhaiya, on the table, if I feel that there is osteoporosis, I'll put an extra rod. That might cost you extra, but don't panic. It is going to be a permanent part of your joint.
Sir, as Ratnagar sir has put up that 20% patients have anxiety and depression element. So do we have a role of psychiatry pre-assessment?
Yeah, Nitin,
if
not
we
routinely.
realize.
Not routinely. We don't do that. In fact, we are planning to do that, but not routinely.
If we
Some
realize,
of the patients, Nitin, you will come across a chronically
because I've seen many of my relatives who are somewhat dissatisfied after the surgery. At least the initial few months, first 6 months they are.
Yeah, definitely. It makes definitely sound practice, but not routinely. But you can pick and select. Some of the patients, you know that these guys are going into depression.
Yes, thank
you. Sir, role of CRP and ESR, sir? Any roles?
We do CRP.
Yes, CRP and ESR is done in all the routine screening itself.
All routine investigations.
Sir,
Again,
after
the
the
ESR
UT
could be elevated in any of the inflammatory arthritis. So only the ESR is elevated, but your CRP is normal, then you need not worry about that one.
Okay. Any cutoffs regarding like
No. So look into the symptoms from the patient. If the patient is not looking, CRP is an acute marker. If the patient is having any active infection anywhere, then only it will be elevated. Okay. But ESR is not an acute marker.
Okay, so if the patient is having UTI and we are giving, in that case, if CRP is elevated and any cutoff is there, so if at all we are waiting
no,
for
that is
5
what
days.
we were telling. If it is a symptomatic UTI, then you need to go for the culture and give antibiotics. Hold on for your
according
surgery.
to the sensitivity.
If the patient is
Sir,
asymptomatic
any
bacteria,
peripheral
then you
vascular.
need not get your cultures. You can just go ahead with your surgery.
Okay. Thank you.
So is 5 to 7 days of antibiotics sufficient before we take up the patient after an UTI episode, symptomatic UTI episode?
Yeah, again, see that if the patient's symptoms should subside, and usually 5 to 7 days is sufficient.
Enough.
Yeah.
Shall we go
Thank
to the
you.
next session?
Just one question, Ratnagar.
Yeah.
Yeah. Suppose there's a patient of who is a diagnosed case of osteoporosis, and he comes for a TKR. So should we just go ahead or maybe wait for 3 months, 6 months, and
Yeah. So do you know any of the medicines which can treat osteoporosis in 3 to 6 months? It is not possible.
But then-
Osteoporosis management goes for years together.
Yeah, but only thing is the risk for periprosthetic fractures. Does it has any
No,
role?
no. Just using some teriparatide or denosumab for 1 dose or 3 months will not decreases the risk of periprosthetic fractures. So just you should be taking many precautions during the surgery. Like sir already mentioned, you should be keeping ready for the rods, everything in the surgery. And post-operatively, you continue the management for osteoporosis.
Another important point for osteoporosis or rheumatoid disease is your sizing of the tibial tray should be absolutely spot on. It should sit on the cortical bone. If you put it undersized, anything, if it is not touching the cortex, it will sink in no time. So be careful about that.
Sir, in case of peripheral vascular diseases or peripheral neuropathy, these patients are relatively contraindicated for the TK.
There is a slide for this one in the next talk by Dr. Tarun.
What is the question? Peripheral vascular disease?
Disease or peripheral neuropathy, is these people are relatively contraindicated for the TKR? Or
No, not
for
at all.
the TKR?
There are plenty of patients with osteoarthritis will have a peripheral neuropathy. Peripheral neuropathy is almost like a diabetes, common everywhere.
Yeah.
So you don't need to. It is not a contraindication at all.
His question was about peripheral vascular disease. So usually they get this ankle brachial index, and if it is less than 0.9, then your vascular surgeon sees first. You see if patient is already having any symptoms of peripheral vascular disease like ulceration or very feeble pulses and is severe claudication pain, walking distance of less than 100 meters, then definitely you expect more complication in these patients, and let the vascular surgeon see, and then you can plan for surgery.
And as we learned during our training that one joint above and one joint below should be normal. So how do we go about scanning about hip and ankle? Because very chronic of patients of osteoarthritis, they do have deformities, planovalgus deformity at the feet.
Yeah, Dr. Nitin, again, Dr. Sandeep, Dr. Tarun has a slide for this one in his presentation.
Yes, I'll be explaining about that.
Maybe we are too early. We are more enthusiastic. Yeah, thanks. Sorry, sir.
So if everyone is okay, we will move.
We need people like you, Nitin, as enthusiastic as possible, my friend.
Thank you, sir.
That will stimulate the discussion. And come on, the in-house fellows, Shravya, Dhruv, and you also keep adding to the value. Ask questions, answer the questions. You're all ready to answer.
Yeah. Right. We are ready to postpone any of the talks to the next week because of the time factor. You can take as many number of questions we want. We are ready for that one.
So what about the DMARDs and biologicals? Whether we should stop it?
So again,
Rajiv, I think let Rajiv
has to be stopped.
Rajiv is the man who
Sir,
gave the
yes, sir.
He has
So
got
the DMRDs and biologicals has to be stopped only for the 24 to 48 hours or anything. They can restart it after 48 hours, and they can consult a rheumatologist post-operatively and then restart it again. But there's no point of stopping more than that.
Yeah, if the patient is on the steroids, you just discuss with them. They will, of course, if the patient is on steroids, you won't stop the steroids, but you will transfer to some other things like injectable steroids that the anesthetist will decide.
If the patient has come on wheelchair, then what red flags points should we be able to think of?
Wheelchair since how long?
Time duration first.
Yeah. So otherwise, a lot of patients come in the wheelchair. You will let them walk and then see how the things are happening. If he is on wheelchair for more than 1 year or 2 years, then you should do a color Doppler and peripheral angio to see any thrombotic element in the patient. limbs.
Yes.
Okay, right. Now let's go to the second talk. Tarun.
Yes, sir.
Okay, go ahead.
Sharing my screen, sir.
Yes, sir.
Can you see the screen?
Yes, sir, we can. Presentation mode, please.
Yeah.
Yeah. Fine, Tarun, you can go ahead.
Yeah. Good evening, everyone, and welcome to the first week of the virtual fellowship in primary total knee arthroplasty. I'm sorry this was supposed to be the first talk, and most of the doubts and the questions have already been asked, and I'll try to clarify some of them. So clinical examination of the knee is what I'll be talking about today. Clinical examination of the knee, as we know, since our PG days, is a very vast topic on its own. And each ligament and each structure of the knee has its own specific special test. So what we will be doing in this seminar or in this talk is I'll only be covering the essential things that we need to diagnose arthritic knee and the clues and the tests that we need to do to get relevant information that helps us plan our surgery. So first thing that we need to assess in a knee examination is, of course, the gait. As soon as a patient comes to your office or your clinic, the first thing you need to observe is the gait of the patient. And the gait should always be evaluated in two planes, both in the coronal and the sagittal plane. Patients usually present with an antalgic gait, or there will definitely be an antalgic component where the stance face is shortened on the affected side. The varus thrust gait is the most common type of gait, usually seen in varus deformities and most commonly seen in primary osteoarthritis of the knee. It's usually suggestive of an LCL or PLC insufficiency. A valgus thrust gait is usually seen in valgus deformities and usually suggests an attenuated medial collateral ligament. High stepping gait usually seen in foot drop or a common peroneal nerve injury, very rarely seen, but has to be taken into account. So the gait analysis of patients with knee OA is there is a progressive change in the, as arthritis progresses, the gait also progresses. And this is a good paper to go through to understand how the gait changes. And these are a few examples of how a varus and valgus thrust gait knee looks. So if you can see, the lady on the left has a very severe varus knee, and you can, while she's walking, you can see how the knee joint is being pushed away from the midline, which is called the varus thrust. It is seen more clear in the gentleman in the middle. If you see, only his left knee has the characteristic varus thrust that we described. So you can see how it is moving away from the midline. And this is how a valgus knee with a valgus thrust looks like. You can see that the knee is moving towards the midline on load bearing. And she's also having a scissoring component where she's actually crossing over at each face. And this is why you need to see the knee in two planes and not only in one plane. So in this patient, you can see the classical recurvatum knee, where the knee is being pushed behind. The reason to assess all these types of gait is it helps in planning so that we can keep the armamentarium that is necessary ready during the surgery and not be shocked by last minute changes. Now coming to inspection. The inspection, as we know, some people in the chat had already asked about cellulitis and how we deal with it and what it is. So always have a good look at the skin condition, both from the front, the side, and the back. And there are usually deformities, swellings or deformities seen in each aspect. Make sure you have a good look at all of them. So this is a cellulitis picture that is classically seen. You can see the redness and the discharge that is coming out from the limb. In such conditions, it's ideally best to treat the patient with the necessary antibiotics and wait out till the skin condition settles, and only then go ahead with your total knee. Drug reactions like this also may be seen, and make sure it's thoroughly evaluated with the physician, and make sure that you know what drug is causing the reaction so that you won't encounter this post-operatively. And the next most common scenario that you encounter are patients with multiple scars due to previous surgeries or injuries. And in such case, there are some few rules that you can follow in patients with multiple scars. The idea is to try to stick to the midline approach as far as possible for your TKR. If there are multiple scars, always choose the lateralmost scar to go ahead with your TKR, and always try to maintain a 5 to 6 centimeter bridge between two scars. Again, inspection from the front. This is just a normal patella, just to show you how a normal knee joint from the anterior aspect, just to show you how it looks like. There should be a patella hollowing on both sides. If there is joint effusion, usually this will be filled. Always look for muscle wasting. Muscle wasting is a very important indicator of an old injury or an inactive quadriceps. That is again a warning point. Some normal conditions that you may see are a bipartite patella, where superolateral prominence may be seen on the superolateral aspect of the patella. Another common condition associated with osteoarthritic knees is Baker's cyst, which is seen on the posterior aspect, usually appears in flexion, disappears on extension, which is nothing but an outpouching of the synovium. And next, you have to palpate the joint through and through. Always look at both bones, the femur, the tibia, and the patella. Look at where the patient complains of tenderness. Have a good look at the patella tracking and make sure it's tracking normally. Check for mediolateral stability by varus and valgus stress test. I'll show how it looks like in the next slides. And always look for the anterior or posterior drawer test also to assess the stability of the cruciate ligaments. Look for the range of motion. If there is any fixed deformities like fixed flexion or recurvatum, and look for extensor lag, which means if the patient can straighten his knee actively. And last but not the least, always have a neurovascular examination done also. So these are some of the special tests that you need to do, especially in a patient with arthritic knees. This is the varus stress test, where you try to push the knee away from the midline. Valgus stress test, you try to push the knee joint towards the midline. The anterior and the posterior drawer test that we all know about. The main reason for evaluating this test or doing these tests is to see how correctable the deformity is. The more correctable the deformities are, the more likely you can get away with the primary prosthesis. And the more severe and the more fixed the deformities are, the more likely you will need to increase the level of constraint. You will either need to put a posterior stabilized or a varus valgus constraint type of prosthesis, depending upon the severity and correctability of the deformity. That will be dealt in detail in later classes. So this is how you assess for a varus and valgus stress. You can see that the knee is correcting to neutral, even though there is a varus deformity. Assessing range of motion for the patient. And this is a patient with positive anterior and posterior drawer test. Another thing to be very aware about is a patient who comes with a stiff knee, which is defined as a range of motion less than 50 degrees. Or it can be either in flexion or extension. You have to find out in what range of motion the contracture is, whether it's fixed in flexion or fixed in extension. And an ankylosed knee is something which has no range of movement. The reason why stiffneys are important are, as Gurva Reddy sir was telling, any patient who has a long-standing fixed deformity which you are planning to correct, always get a thorough vascular examination done, which is through assessing the peripheral pulses, and also get a venous Doppler of bilateral lower limbs before going forward for surgery. The next most thing, once you've examined the knee, always look at other joints also. Always examine one joint above and one joint below, like someone was asking. And if there are two joints which have the same amount of symptoms and the same amount of pain, the dilemma is which joint do you choose and how do you decide which one to go forward with? The rule of thumb is always choose the proximal joint first. So in case a patient has a hip and a knee both involved to the same degree of arthritis, always go for the hip replacement first. Again, this is just a rule of thumb. There can be exceptions, and the most severe joint should ideally be taken first. Always examine the spine from the cervical to the lumbar and lumbosacral region, like sir was mentioning. Always look for pre-existing neurological deficits, very important. And at the foot and ankle, always look if the patient has any flat foot, in-toeing, out-toeing gait, or any hind foot valgus. All these may also play a role. And also look at small joint involvement, which is suggestive of inflammatory arthritis or gout. And coming to the debate of whether a knee surgery or a spine surgery should be done first. In general, the spine surgery is always done first if it is symptomatic. And only severe varus or valgus deformities of the knee will be chosen first. Another thing to be worried about, like someone was asking regarding peripheral vascular disease, is claudication pain. Claudication pain is pain that occurs during walking or exercising, and it's mainly caused due to the lack of blood flow to the muscles in the legs. There are two types of claudication that we need to be wary of. One is the neurogenic type, which is caused by compression in the nerves at the level of the spine, which is way above, caused by stenosis, discs, or spondylolisthesis. And vascular claudication, which is caused by a blockage of the arteries of the legs, usually seen in atherosclerosis and diabetic patients. So there are a few ways which you can distinguish between the two types. The main thing that you have to see is like Ratnakar sir was saying, is the ankle brachial index. This is how you decide what type of claudication the patient has. If the patient has an ankle brachial index of less than 0.9, it is more likely a vascular claudication, and always should be evaluated by a vascular surgeon whether he wants to go ahead, and only after his clearance, you can go ahead with your total knee. A neurogenic claudication is again due to a spinal cause, characteristically seen by a relief in pain on bending forward. Vascular claudication, on the other hand, is they have something called as a claudication distance, that the patient tells you that he can walk for a certain distance and only then the pain starts, and on taking rest, the pain relieves. That is another indicator of a vascular claudication. And last but not the least, once you have decided and planned for a total knee arthroplasty, always remember to do a functional scoring assessment for your patient. You can use either or multiple scores, like the Oxford Knee Score, Knee Society Score, the KOOS, or the Forgotten Joint Score is post-op. But all these scoring systems actually help you track the progress of the patient from the preoperative time up to consecutive follow-ups. You can see how your patient has improved over time. And in fact, you can also show the patient with documentation as to how their scores are improving with time. This is a good practice to follow in your daily thing. And you can use this website if you want. They have already pre-fed and built-in scoring for these tools, which will give you a direct output just by clicking the options in the tools. Thank you.
discussion about this particular topic.
Practically, does the patient allows, because the patient is in severe pain, how much the patient allows for us to see this possible correction of the deformity, whether it is correctable or uncorrectable?
That you don't need to force, Nitin. Just simply make him lie down, keep chatting, and just simply put a varus valgus test. It will come back. Don't worry.
Yes.
Whatever pain, that 1 second is good enough. Abhay Kulkarni from Pune.
Yeah, sir, does the flat foot, make any change in our surgery plan?
Not much, not much. There are plenty of planar valgus feet. Rheumatoids come with the gross deformities of the feet. I have not done a single foot surgery secondary to knee replacement. So no doubt, post-operatively, they keep on sometimes complaining about the foot pain and all that. But we got to ask them to wear a nice corrective shoe, that's all. But otherwise, theoretically, yes, but practically, no.
No. Thanks.
Yeah, Vipin.
Sir, is limb length discrepancy, if the patient has some limb length discrepancy, how do we adjust?
So patient limb length discrepancy, you cannot adjust it by knee replacement. If you got a malunion of the femur with a shortening of the femur, you cannot put a increase this thing and change the joint line and all that. Marginally, you will get, let us say, probably to 1 centimeter or so, but not more than that. And so sometimes the operated limb becomes longer and the other arthritic limb becomes shorter, and patient can perceive that. Then you explain to them that, look, my friend, until you get the other knee, you have to walk like this, and pelvic tilt will compensate for that. So seldom you need to give a shoe raise for that.
What about, sir, a hemiplegic patient, which have some hemiplegia patient?
Hemiplegia patient, you can do the surgery on the opposite side. He will walk with a hemiplegic gait or with support of the walker or stick. So if the hemiplegic gait, the arm is a bit heavy, then I would like to put a rod on this side so that he can take the heavy load on this joint.
Thank you.
Sir, out of the 4 scores you have mentioned, Oxford Knee Score and the Knee Society Score, which one should we go through and read it?
Well, I would suggest going for the Oxford Knee Score because it's a patient-reported outcome measure, also known as a PROM. So it overall deals with how satisfied the patient is and how satisfied they are with the total knee replacement, more than how a surgeon wants to perceive it.
Yes.
Yeah.
Thank you.
So in case a patient has a spine problem and hip problem and knee problem all at the same time, in which order should we go ahead with the operations if we suppose he needs all the operations?
Severity of symptoms, sir. So the most severe would be ideally dealt first and preferably spine, and then going downward.
Proximal to distal.
And also here, I would like to tell one important point. A thorough spine, suppose spine problems are there, especially associated with weakness. A thorough spine examination, including nerve conduction test, to be done. A neurologist will tell whether the lesion is progressive or static. If it is a progressive, you should be very careful in taking for total knee. That is very important point. Then we can go depending upon the symptoms, as my friend told. Another 1 or 2 small tips for clinical examination is, one is skin. Sometimes a psoriatic patch or fungal infection or eczema and the pigmentation of the limb, these things may be there. We have to show the dermatology and know what is the reason and before taking surgery. And another point is, full clinical examination before surgery, preoperatively is very much required. Then after anesthesia, so full relaxation, better to have one look on the flexion and extension and varum and valgum, because sometimes in rheumatoid, these deformities will disappear to some extent. That will give some idea regarding your cuts and soft tissue releases. So after giving full anesthesia, also one clinical examination in correlation with the X-ray is also important, so that we'll have some idea which cut we have to do and where we have to release. And finally, On your clinical examination, patient is giving lot of pain, but knee found to be normal. Don't forget to see the hip. Sometimes the hip problem, he will not complain any pain in the hip, but he will come only with the knee pain. So be careful about it. I mean, patient should be examined in toto, starting from toe to at least until neck, and the thorough examination is required and recorded all these findings so that no mistake will be occurred, because you are undertaking a little bit major surgery of total knee replacement. Before that, assessment in totality is very required, rather than locally doing only clinical examination of the knee.
Sir, any Parkinsonism, does it have any bearing on the TKR?
Yeah, very much. Very much. Parkinsonism is not a contraindication, but it's all depending on the communication. Because Parkinsonism, the way I deal with is, I tell the patient and the relatives that, look, there are two great benefits out of knee replacement. Benefit one is pain relief. Benefit two is ability to get a good gait or improvement in the gait. But in case of Parkinsonism, you will not get the second benefit. You will get only first benefit. That is pain relief. That much I can guarantee you. The gait might be marginally better, but your gait disturbance and your shuffling gait is not because of the arthritis. It is because of the central defect. So that will not change. And third point, I'll tell them, sometimes knee replacement can aggravate Parkinsonism. Exact cause is not known, but sometimes Parkinson's can go to the next grade. That also you should tell them. But you tell them this operation is only for the pain relief. And if they are sold to that, if they are convinced to that, then only offer the operation. And third point is, physiotherapists you cannot do routinely. They have to spend more time and give a Syndopa tablets and let the muscles relax and then start taking the physiotherapy. So these 3 or 4 important points in Parkinson's. I have done many, but the preoperative communication is very vital.
Thank you.
Just a point to be added is, we have seen couple of patients coming for TKR and they are de novo diagnosed to be Parkinsonism on clinical examination or something. So these patients, if they are started on Syndopa, there is a lot of improvement in these patients. So always start these patients on Syndopa before you start take for TKR.
Yeah, that's a good question. A lot of the times in the clinical examination, while you are putting your heart and see the patient is slow. If you ask him to show the knee joint, it takes 2 minutes to unroll the pants, or he looks at you blank. Parkinson's is a clinical diagnosis, provided you know what it is. So that's why you got to keep looking at the face. If he is talking slowly, the relatives also don't know. Then you send them to a neurologist, bang, he is a Parkinson.
So what to do in case of a stiff knee? If it is stiffness is more than 50 degree. So
yeah, we got lectures, complete lectures on that. We got a stiff knee, we got a recurvatum knee, we got a valgus knee, we got a varus knee. So wait for that, you will get all the answers.
What is the minimum power needed for going for TKR, sir? Corticeps power should be more than 3? And it's
usually yes, but I have done it in polio also, grade 0. But the thing is, you got to tell the patient that post-operatively, she will need to have a locking brace, hinge brace. So basically, the patient will lock the brace and walk with a straight leg. And while sitting, she will unlock it and bend the knee. So that's what it is.
Thank you.
But patient has to accept that. Again, preoperative communication.
Any difference in a varus gait and a varus gait with a thrust, varus thrust? Does it tell us anything about the planning for surgery? Does it change our plan? Nothing much. Basically, varus thrust, you'll have a lot of subluxation and posterior loss of the bone. So you got to be prepared for that. A simple varus knee, whatever you see on the X-ray, you will get it on the operating table. But varus thrust, it is much more than that. So be prepared to fill the bone defects. That's all.
Bone defects and the constraints you need to plan.
Yeah, and the ligaments also will be more stretched than normal. So be prepared for the constraint.
So foot deformity before we should assess, and any protocol post-op or post-surgery of this foot deformities, secondary foot deformities following ONE?
Tarun.
So regarding the foot deformities, if it is just simple flat foot accompanying a valgus knee or something like that, it doesn't need to be addressed per se. Only if it is a post-traumatic or a very deformed foot that it affects his normal ability to walk even after restoring your mechanical access, then it's something that you have to be concerned about. Otherwise, you can go with your TKR first.
And one more important thing is, in some patients, ankle pain increases after total knee replacement.
Yeah.
And in some patients, ankle pain decreases after total knee replacement. So in post-op TKRs, patients do complain ankle pains who have not complained ankle pain in the before because of change in biomechanics. We have to be aware of that also.
But it is a temporary phenomenon that will slowly adjust. You got to reassure the patient. As I said, in my 25 years experience, I have not done a single ankle operation after the knee replacement. Okay. Usually they will get used to it. Yeah. Okay. Right. Ratnakar, what is the agenda?
Yeah. The last talk by Dr. Sandeep, sir.
Yeah, go ahead.
So preoperative X-ray. Okay, Sandeep.
Going forward, sir.
Yes, Sandeep, please.
So let us go forward for the preoperative assessment. Myself, Dr. Sandeep. I'm a joint replacement surgeon in Sunshine. So standard radiographs include anteroposterior view, supine and weight bearing view, and lateral views with 30 degrees flexion and skyline views. And we have to be always be concerned about magnification whenever you are templating and all. For example, this is a standard anteroposterior view. As we can see, we ask the technician to take an anteroposterior. We can see. We will discuss this. So here we have a femur, and here we can see patella is in midline in green color. And this orange thing is a femur, and here we have tibia, and we can see the condyles. And we need minimum amount of exposure of the femur and tibia also while going forward for a TKR. So these are two X-ray views. For example, if you can see on the left, we have an anteroposterior view with the fibula maybe around the 20 to 25% overlap, and in the left, in the right side, we have anteroposterior view in rotation. So do not accept this kind of X-rays where we have rotations, because, for example, if you can see in the left, the patient, the knee joint is internally rotated. It looks like the knee joint is in valgus, but this is a proper AP view with no deformity. And whenever you can see on the right, this joint is externally rotated and it looks like it is in varus, but it is not like that. So as a rule, if you see fibula completely, if you're able to see a lot of fibula, this is internal rotated view. If you're not able to see fibula and it is behind the tibia, it is definitely an external rotated view. So be aware of that. And lateral view will take in 30 degrees flexion. And here we have patellofemoral joint, tibiofibular joints in the lateral view. We can see two condyles, medial condyle and lateral condyle of femur, which are overlapping each other in this case. And this is tibia. And skyline view, we are aware of that. And after getting an X-ray, first let us grade the X-ray. For example, we have Kellgren-Dolan grading, which is most commonly used. Grade 1, it is doubtful where osteophytes formation is not there. And in mild, where there is doubtful osteophyte formation, moderate, where there is definitive osteophyte formation, and there is reduction in joint space on the medial side, as we can see in the third one. And in the rightmost one, we can see joint is completely reduced with subcondylar scoliosis, which is a severe grade of osteoarthritis. And mine, we have to take a weight-bearing X-ray only while getting knowledge. For example, here we can see on the left, this is a knee X-ray of a patient we have operated recently. Here we can see medial side bone-on-bone arthritis of the right knee. And when we go into the surgery, here we can see this is a intro picture of the same patient with medial side complete cartilage worn out of the medial condyle of femur. And let us see this X-ray. Here it looks like medial joint space is maintained. We have a decent gap. We have slightly doubtful osteophytes, but unfortunately, this is not a weight-bearing X-ray. Intraoperatively, when we went into the surgery, here you can see medial condyle, this cartilage is completely gone. So if this was a weight-bearing X-ray, definitely there'll be complete narrowing on the medial side. So point number one, always get weight-bearing X-rays for total knee replacements. And also, for example, if you want to calculate the alignment, knees become more varus about 2.2 degrees on standing compared to supine positions. So there'll be definitely difference in hip, knee, ankle axis while you are checking for standing and supine. So for example, you want to template, you want to check for values. You have 3 softwares which are for free, which are present online. IC Measure digital software from Germany, SurgeryMap, which is for PC, personal computer, SurgeryMap spine software. You can measure angles, you can also check it. And also you have protractor application in iPhones and regular Android apps also, which you can calculate angles and calibration. For example, here we use a coin, white colored coin, and we feed the diameter of the coin to the software so that it calculates approximately how much the tibia and femur sizes are. So scanogram, is it necessary? Yes. To rule out extraarticular deformity, to rule out stress fractures which may be well away from the knee joint, and planning of axes and angles. Patient should be standing in maximum extension possible. Both feet should be around 30 centimeters apart with 10 to 15 degrees of interrotation, which is a good scanogram. Here we can see a scanogram. Here we can see, and this is a scanogram which is stitched. For example, they take 3 X-rays, one at a hip, one at around knee, one at around ankle, and they stitch these 3 films to get a scanogram. And here we can see, if we see this here this is the lesser trochanter. Lesser trochanter should be 50% visible. This is a good AP scanogram view. If it is more than 50% visible, it is an external rotation. If it is not visible, it is an internal rotation. So that is very important. And here you can see there are multiple papers which say scanogram should be definitely taken because we'll discuss it later. And here we can see scanograms generally give only anteroposterior view. So here is a scanogram of our case. Left side, we have a long tibia, which looks absolutely fine. But clinically, patient was complaining tenderness on the proximal tibia. And whenever you have such doubts, take proper imaging of that entire tibia other than scanogram. For example, here we can say in the lateral view, we have found a stress fracture in the proximal third, middle third junction. So don't just get fooled with only AP view. Always get 2 views. And this is an example of stress fracture, which was lateral managed with totally replacement along with the rod. So what information do our X-rays give? What is the deformity? For example, you can see left side it is varus, in the middle it is valgus, in the rightmost column there is no deformity, it is a rheumatoid knee, uniform reduction in joint space. And what is the magnitude of deformity? You can calculate it with the angles. And here you can see in the left side stress fracture, and in the middle also there is a stress fracture. In the right side there are extraocular deformities, and whether any implants are there. For example, you are doing a primary total replacement and you definitely have to put intermedullary rod in the femur. So if there is any intramedullary implant in the femur, this will be hitting that. So that also you have to be ready. And what is the amount of bone loss? So left side mild bone loss, in the middle you have moderate amount of bone loss, in left side you have severe bone loss. So this is only for planning. In the surgery you'll be ready with your all the armamentarium. So you have to have an idea. And osteophytes. Generally, why do we get osteophytes in osteoarthritis? In the long-standing osteoarthritis patients, there is decrease in stability. So these osteophytes increase the stability of the joint. So generally when there is osteophyte, this is a long-standing problem. For example, in rheumatoid arthritis, where the destruction is rapid, osteoid formation is less. And be aware of the osteophytes which are present on the posterior part of the femur, because they will be affecting your extension gaps, which we'll be discussing later. And we have to idea, okay, there are large amount of osteophytes in the posterior, we have to remove them, if not our extension gaps will vary. And this is a proper hip knee scanogram. So here here we can, in the left we can see in the image, the line is red like color, line is drawn from the center of the hip to the center of the ankle. This is the mechanical axis of the lower limb. In the middle we have a red line femur in the red line in the femur, which is anatomical axis of the femur. A red line in the tibia, anatomical axis of the tibia, and there is 10 degrees angle between them. And in the right side, third image, we can see mechanical axis of the femur and mechanical axis of the tibia, which are making a 15 degrees angle between them. And now we come to the valgus angle. So valgus correction angle is the angle between mechanical axis of the femur and anatomical axis of the tibia and femur. So this is, in this image, you can see this is 5 degrees. So in total knee replacement, we use valgus correction angle as routinely 5 degrees, but no, that is not good. For example, if the femur is some 30 centimeters, if the one versus femur is 45 centimeters, definitely there will be difference in valgus correction angle. And this is not a fixed value of 5. The range is 3 to 7. So definitely we have to calculate valgus correction angle for every patient and cut appropriately during the surgery. And what is mechanical axis deviation? Here we can see one dot in the center of the tibia and mechanical axis. The distance between the horizontal distance between those both is the mean mechanical axis deviation. For every 1 degree varus or valgus, mechanical axis moves for about 5 mm away from the knee joint. So normal mechanical axis is definitely away from the midline towards the medial side. That is the reason most of our osteoarthritis are medial. And we have Canadian wide zones. These are it is divided into 6 zones: 1, 0, 1, 2, C, 3, 4, and 5. The zone where mechanical axis is crossing the tibia is the zone. So this is for communication purpose. So next we have to measure tibial slope. So tibial slope is the angle between anterior cortical line and the articular surface of the tibia, and its values varies between 3 to 10 degrees. We have to calculate. And the significance will be dealt during the surgical videos. And posterior condylar offset. So it is the distance between posterior femur cortical and tangent line to the posterior condyle. So how important is it? It is very, very important, because 2 mm decrease in posterior PCO will reduce the post-operative knee arm by 12.2 degrees. So PCO should be restored. And from now we will be hearing multiple times joint line elevation, joint line depression, joint line. So what is joint line? Height. So this is the joint line, which is in the yellow, and we can see multiple bony landmarks in our knee joint: lateral epicondyle, medial epicondyle, fibula head. Generally, what we lateral epicondyle, medial epicondyle vary; they are not small points. But fibula head is a definitive point. So joint line height we measure from fibula head to the joint line, vertical distance. You can also measure it from medial and lateral epicondyle also. So to see whether your joint line is restored or not. So how templating, definitely there is value, but limited value. For example, you can use your X-rays, you can use templates, you can put these templates on your X-rays with proper magnification and assess how much is the size of femur and tibia. For example, you're getting a size of 1.5. Check whether your armamentarium is definitely having 1.5, because so many implant guys say 1.5 is not there, 2 is not there. So be prepared. And patella. What is proper positioning patella? Here with a thick line, thick arrows, we can see the fascial scar, and with a thin arrow, we can see a Blumenstadt's line. Your patella in the lateral view, when it is taken in 30 degrees flexion, will be between these both lines. And next is insula-salvati ratio. So insula-salvati's ratio is the ratio of the length of patella tendon to the length of patella, which is around 1. More than 1.2, it is patella alta, which implies patella is above, and patella baja is below, which signifies with the insula-salvati ratio of less than 0.8. So 1 is normal, 1.2 is above is alta, 0.8 below is bar. And next we go for valgus varus stress tests, stress X-rays. For example, here you can see in the left side there is a varus stress given, medial side is completely obliterated, so medial cartilage is gone. Whenever we give a valgus stress in this X-ray, you can see lateral side it is maintained. So this is a typical feature of anteromedial osteoarthritis. Same. So here is an intra photo where medial side is worn out, lateral side is maintained, ACL is normal. So this is a picture of anteromedial osteoarthritis, where you can go for partial knee replacement rather than total knee replacement. So next is standing AP view. Everyone knows it, but there is also a standing posterior anterior view, PA view. So posterior anterior view is taken in 45 degrees flexion. So AP view is taken in extension, complete extension. PA view is taken in 45 degrees flexion. AP view is almost the femorotibial articulation in mid-coronal plane, but whereas PA view, the articulation is with the posterior femoral condyle. So whenever your knee is flexed to 45 degrees, the contact point goes posterior. So it signifies posterior tibiofemoral osteoarthritis or wear rate is there. Here it is the same exercise of same patient. Here, by seeing the left side X-ray, you may see still the joint line is cartilage is maintained and all, but with posterior anterior, you can see there is complete obliteration. So whenever you have discrepancy between the X-rays and your patient's complaints, you can go forward with this X-rays. And there are some views, tunnel view, which is taken in 60 degrees flexion, which signifies posterior condylar diseases. And this is X-ray where you have calcification of arteries, which can seen in the posterior to your knee joint. So whenever you have calcification, go take a vascular consultation, go for a Doppler if needed, and do not use tourniquet during the surgery, which will prevent incidences of post-trauma. And now with all this, are you ready for total knee replacement? But still no, you need a lot of observation in the cases. For example, you can see this case. When I first saw this X-ray, this was simple X-ray, varus deformity. We were going to operate the right side. We went forward for surgery, and this was the intraoptic. We had a large cyst on the medial femoral condyle and multiple cysts in the lateral femoral condyle. Now you can see MCL attachment MCL is attached to very thin bone on the medial femoral condyle, and it was very scary. Now going back to the same X-ray, this is the cyst. We can see cyst and one more cyst on the lateral medial femoral condyle, one cyst on the lateral femoral condyle. So these are very scary. Now, after complete cuts and all, this is the final situation. So this is a very scary situation during surgery, especially when you have only primary implants in hand. For example, you are in a small setup away from the city and you have accepted a total knee replacement. Now you have landed in this problem. This patient will definitely need a femur rod. If not, it is not possible to finish the surgery. And maybe we might have a valgus varus constraint implant in the standby also. But whenever you have only primary implants, you don't have femur rods. For example, we have femur rods only for DPPFC. For example, for MAX and BP, primary implants, they don't have femur rods. Now we are struck. And this is the outcome. We had to put a rod. We had to put a lot of bone graft on the medial and lateral femoral condyles. But this is okay. We have a good setup and all. But what if you are in a small setup? You'll be struck. So take care. Observation is very important. And not every time you need a proper anteroposterior view. For example, this X-ray we recently operated, anteroposterior view looks to be fine, medial side osteoarthritis, but something was fishy. Patient had recent history of some 10 days of bedridden thing, some 6 months back. And here we can see the notch was slightly doubtful. So patient was walking well, patient had no pain on the femur. He was definitely walking with severe limp. We thought it is because of osteoarthritis. And this is a rotated X-ray. So we took a rotated X-ray. So you can see fibula is behind. So we took an external rotated X-ray. Here we can see midline split of the femur. Now retrospectively, when we asked the femur, he told, yeah, I had a fall. I took rest for 15 days and then started walking. Definitely the history is not matching with this X-ray, but now we have a big problem during surgery. Now retrospectively, when we go back, we can see there is a difference in notch. This notch is discontinuous. So then we went forward for surgery. And we had to use a femur rod. We had to plate the femur also. So it takes a lot of effort. And not all primaries are simple. Here we can see a large bone defect on the lateral side. For this, don't go with just primary implants. So now this fellowship is regarding primary total knee replacement. So this doesn't qualify into it. Okay, be careful whenever you get such X-rays. And sometimes your femur may be completely gone. For example, here we can see a previous history of GCT, a lot of cement in the canal, very difficult to negotiate rods. You have to put intramedullary femur rod. It is not possible now. So be careful during these surgeries. And these are a bit more complex primaries. For example, in the left side, you have a non-union, you have a broken implant. In the middle, you have a removed proximal tibia, and there is non-union in the proximal tibia, which may need a proximal tibia replacement. And in the right side, we have non-union and broken implant with the extraarticular deformity in the tibia also. So you need a lot of armamentarium, and these surgeries cannot be done with primary implants. So, okay. And this is it. And finally, I want to conclude by saying that you just keep seeing X-rays, but definitely correlate them clinically. Thank you.
Yes, we are open for discussion.
Yeah, well done, Sandeep. Very well done.
Thank you, sir.
I'm really glad and happy that all three of you have done extremely well. Okay, good. Yeah, questions?
Can we go ahead with without orthoscanogram? In like I am working in a tier 3 city.
Yeah, you don't need a scanogram. But only thing, be careful. Sometimes if the patient gives a history of any fractures, then malunion of the femur and tibia, those you have to take it. Or you can take, if you are conscious, you can take 3 separate x-rays and ask your radiographer to stitch them for you. One hip from mid-thigh to knee joint and below below the one up to 1/3 of the knee. But your scanogram is not a mandatory for a regular practice.
Like it was mentioned, to correct the valgus angle, we have to measure between the anatomical and the mechanical axis of the femur, 3 to 7 degrees, which can only be taken on a scanogram. So we can avoid that.
Yeah, theoretically, yes. But in practical terms, most of the time you can put 5 degrees valgus and in the femoral cut and get on with it. As you gain experience, you will get that one.
Once I had a very peculiar experience. One of my relatives who was going for TKR, and he had more of X-ray changes on the other side, and he has more pain on the other side. So the arthroplasty surgeon in Delhi, they had a very difficult time in convincing him that he should get both the knees up, because he was of the opinion that because he has pain on one side only, so he should get himself operated on that side.
Yeah,
but the X-ray
recently
changes, discrepancy between the two things, the X-ray changes and the clinical patient presentation.
The answer is recently in Coimbatore also, the discussion has come. Some people have disagreed with me, but my practical solution is, if the patient, time and again we come across, if the patient has got X-ray right knee arthritic changes, and you think that that is a need to be done, but the patient has got a pain on the left knee, then the decision is very simple. First, go and operate on the left knee, where the patient has got symptoms, and then you tell him, patient, right in the beginning, you need both knees. So first we will operate the pain which has got more pain symptomatically, and then afterwards we can seek arthritis. Why it is so, I don't know exactly the answer. Sometimes severe arthritic knees do not have pain. I don't know whether there is any pseudo cartilage forms or any fibrous tissue forms, or all the denuded bone will have any second grade fibrous cartilage which makes like a smooth cushion, something like that.
Yeah, it's common. It's a common thing to see.
Common thing, yeah. So you don't treat X-rays and you don't operate the X-rays. First principle. So you just go and operate on the opposite side. However reasonable the X-ray looks like, you will have some arthritis on that knee, obviously.
And one more thing, sir, regarding this X-ray and the clinical correlation, Kellengren-Lorentz classification, which I have explained, stage 4 severe arthritis, is not always right. It has a post-operative value of only 80%. So 20% you will be missing it. So don't always think Kellengren-Lorentz classification is golden standard. No. For example, and one more thing, if the patient knee is only slightly arthritic, sometimes they have acute osteoarthritis exacerbations when they will have severe pain on that knee. So in that time, what we do is we give them physiotherapy, give them medicines for 1 or 2 months, and we check it. If it is acute exacerbation, definitely it will come down. But definitely if it is arthritic, and I have shown in one of the X-rays, in AP view, the joint line seems to be maintained. But in PA view, there is narrowing. So it could be one of such cases also.
Another thing is, on weight bearing, sometimes the medial compartment looks pristine, but the central tibial spine will be abutting on the femoral side. So that also is a painful spot. So in other words, it's like a central collapse. So instead of the joint collapsing on one side, it will just telescope into the central part. And that also will be painful. And there will be a big denuded cartilage in the intercondylar notch of the femur when you open that. So that also is an arthritic. But be careful, in younger patients, don't jump and do the operation. Let us say if the patient is 70 plus, even if the stage 3 X-rays, the patient is symptomatic, you can go and offer the operation. But if the patient is 40, resist, try all the other things, and then only go for surgery. Never ever operate on a lesser arthritic knee because the results are not good.
How long should we wait in case of acute exacerbation of
At
OA?
least 3 to 4 weeks. Acute exacerbation inside the synovitis, outside the joint looks good. Patient limps, and the limping does not correlate with the X-ray findings. Then you give Mobijox, pantoprazole, or some Combiflam for at least 3 weeks, and ask him to give rest, ice packs, and pillow under the knee joint. 9 out of 10 people come back walking nicely. Then you get them back onto the regular OA treatment.
And how long should we wait after the visco supplementation and steroid injection?
Within 2 weeks, I operate.
2 weeks.
Is any contraindication, sir?
No contraindication unless the joint looks to be infected. Recently, I got one patient where he was bucketed with a PRP and patient came with infection. So I got to do a lavage and planning to do 2-stage revision.
Sir, my question is in grade 1 osteoarthritis or grade 2, when there is a synovial hypertrophy and there is a swelling kind of presentation of the knee. So should we give ice fermentation or hot fermentation?
Ice and hot alternate is the best way nowadays. They say that. But acute phase, you can put ice for 3-4 days and then switch on to the hot fermentation.
And someone was asking.
There's nothing. There's something like alternate fermentation.
Yeah,
it is said contrast.
That's what I said. Morning hot fermentation, afternoon ice, and evening again hot, like that.
There is a rule regarding this also, contrast fermentation. 2 plus 1. 2 minutes hot, 1 cold, and 3 times the process. Total, it will take 9 to 10 minutes.
Right, good.
So what is the indication of intra-articular steroids? When is the best time to give intra-articular steroid?
As far as I am concerned, there is no indication at all. I have not given a single steroid injection in my last 20 years.
And someone was asking about CT scanogram. CT scanograms are taken in supine position, so they are not weight bearing. X-ray scanograms are taken in weight bearing, and they will give you perfect, like what is the HK axis, what is the deformity, and all. So for TKR, X-ray scanograms are definitely better than CT scanograms, and you not go for CT scanograms.
Sir, my second question is that how much the kneecap helps in the grade 1 and grade 2 kneecap?
I'm a great fan of kneecap, Shivam, and it's a psychological feeling. The olden days, people used to discourage saying that quadriceps wasting will be there. That is absolute theoretical rubbish. There are so much theoretical rubbish in the clinical practice. There is nothing like. So basically, I give them kneecaps in the daytime and tell them to take off in the night time. So it's simple, but that will give a lot of psychological impact. People are so comfortable. And in grade 3, I give them hinge brace. And sometimes I give them unloading brace. Unloading brace also work well. Yeah.
And sir, what about the quadriceps hamstring strengthening exercise? Do they really work in grade 1 or 2?
Absolutely, my friend. Quadriceps is the Bhagavan Krishna. Your knee joint is Arjun and quadriceps is Krishna. I can't tell you anything more than that. Same thing like hip. Or hip joint abductor is Krishna. You develop these two, you will be the winner.
Sir, MRI is helpful in unicondylar arthritis to see any ligament structures for weakness or anything else?
No need at all. Keep the life simple, my friend. No need of MR scan, no need of CT scan.
Your X-ray will tell whether your ACL is intact or not. Your X-ray will tell it is only medial arthritis. On a true lateral film, if you see the articulation between the tibia and femur, if it is centered to anterior, it means your ACL is intact. And if it is an end on end, then
when you come to do the partial knees, you will know more about that. But for a total knee, you don't need to bother.
So does any medical legal implication if you don't get an MRI before you plan for any CR knees?
Nothing. No medical legal complication. If you go to court, I'll come to court and defend you. Don't worry.
Thank you, sir. Thank you.
Okay.
And regarding PCL, PCL is a structure which is present in even worse to worse deformed knees.
Right.
Sir, should I ask the question about PS knee and CR knee today or next week session?
No. There's a beautiful talk on that. No, don't, my friend. Ask questions only for pertaining to today's classes. Preoperative selection, any contraindications, anything like that. Sangam Jain, enjoyed the class?
Yes, sir.
Okay, good. Funny Teja. I just saw Thakur, Amit Thakur, I think. Somewhere
Yes,
I've seen
sir.
him.
Yes,
Amit,
sir. Yes, sir.
enjoyed the talk?
Yes, sir. Yes, sir. Yes, sir.
Wonderful.
Definitely,
Jamin
sir.
Patel, where are you from? Jamin.
I am from the Ahmedabad, sir. Gujarat.
Ahmedabad.
Gujarat.
Ahmedabad, the birthplace
Yes, sir.
of Chalvi. So, say my
Yes,
hello
sir.
to Vikram. Manoj
Yes, sir.
Khemani, where are you from?
Sir, I am from Kolkata.
Kolkata, wonderful. Good.
Yes, sir.
I can see Rao Sahib Gulve. Rao, where are you from? Unmute yourself, Rao. Unmute.
Hello,
Yeah,
I am from Akloj, Solapur district, Maharashtra, sir.
very good. And the people who are not on names, for example, iPhone and all that stuff, Galaxy Tab S6, please put your names so that it's an interactive session. You will know us, we will know you. We can keep on chatting. Okay. Anirudh Deshmukh, where are you from? Anirudh.
Hello, sir. I
Yeah.
am from Pune, Maharashtra, sir.
Pune, Maharashtra, right. Wonderful. Good. Right. Any other questions? Manjunath, you're happy, man? Manjunath.
One question is there, sir.
Who is that? Who is talking?
Yes, sir. Yes, Jamin Patel, sir.
Okay.
Any preoperative preparation from the patient side, betadine wash and any sterile material cover?
Yeah, that's not bad. A good practice is when the patient comes for OPD and he's ready for surgery, give him a preoperative kit, which probably there is a wash now. Is it, Rajiv? There is a betadine wash.
Chlorhexidine wash is there, sir.
Chlorhexidine wash is there.
Chlorhexidine wash.
Okay, give him chlorhexidine wash. Let him put it in the bath water and let him have a 2 days bath beforehand.
Scrub.
And 1 night before scrub. Nicely. Get him all the nails cleaned up and then come back. That's a good preoperative thing which can do. I
Sir,
can
we
see
have
iPhone. Yeah.
Yeah, we have not
So
talked
any
about
specific practice?
alcohol.
Sorry to interrupt.
Should we advise the patients to how long after the post-op, in the post-op protocol, about alcohol?
Alcohol. You can take alcohol on the day one. That is the best analgesia invented by the God. Okay.
Sir,
No
is
problem,
it
my
for
friend.
is it for surgeons
You
or
can have
patients?
one peg with him,
Yeah,
sitting
that's
next to him. Okay, no
is
issue.
it for
Sir, any specific practice or ritual for VIP patients?
VIP
Because
patients, before
VIP
operating,
syndrome.
go to temple and pray to God. God, save me.
Better to refer to Reddy, sir.
Akram, where are you from?
Sir, I am from Purnia, Bihar, sir.
Oh, Bihar. Good. It's really heartening to see so many people from all parts of India. Amit Thakur.
Yes,
Where are
sir.
you from, sir? Where are you from?
Sir, I am from Jammu.
Jammu, wow.
Jammu, yeah.
That's
Jammu and
cool
Kashmir.
place. Wonderful.
Yeah.
Good. Lovely.
And sir, I am from Bijnor. You mentioned about Krishna and Arjun, the place where Vidur, Mahatma Vidur Nagri.
Oh, wonderful.
Bijnor in West UP.
Very good. Excellent. Really well.
Hastinapur is just
Wonderful.
nearby.
So one question, sir. Osteoarthritis or neuropathy?
Yeah. Somebody asking a question?
Sir, on osteoarthritis with diabetic neuropathy patient. Any
Yeah,
neuropathy
that's
symptoms?
a good question. Usually, diabetic neuropathic joints happen mostly in ankles and feet. And of course, neuropathic knees are also there. But this guy will come with your gross deformities, which is not commensurate with the pain. The whole ligaments are gone. The tibia is east and femur is west. And those sort of neuropathic joints, be careful. Just give them brace. Do not touch them. Tell them go home. Otherwise, if you got any enemy in your place, send the patient to that enemy. Do not touch neuropathic joints. Okay. At least in the first 10 years.
Sir, one more question, please. Sir, in
Yeah.
case of rheumatoid arthritis, isn't it a contraindication, or should we be very cautious in rheumatoid case?
Rheumatoid arthritis is one of the most satisfactory knee replacement patients because they are so crippled. Any improvement in their gait and pain, they will be praising you like anything. So rheumatoid arthritis, the scores are much higher and the satisfaction is much deeper. So only thing rheumatoid, be careful about the softness of the bone and be careful about the other deformities and be careful about the atlantoaxial subluxations, those sort of things.
Thank you.
Myopathy is there.
In bed X-ray करना त्यांचा फक्त.
Yeah.
Should we
Okay.
discontinue the DMARDs or biological?
I think already
agents?
answer was given. Who is that?
Yeah.
Okay.
Rajiv or
We
DMARD?
can continue. The recent guidelines says that
Who gave the
DMARDs
talk?
need not be
I think
stopped.
Rajiv.
Yes, sir. Yes, sir.
Yeah.
So the recent guidelines say that
Okay,
you can continue the DMARDs, but you can
Yeah.
stop the biological agents.
Correct.
Okay, sir. Okay, sir. Thank you, sir.
Sir,
one question, sir.
Yeah, Arun.
Yes, sir. Arun from Kerala, sir. Sir, what about the anticoagulants if you are using, sir? If the patient is on anticoagulants, what are things you have to be careful when we are taking the patient for?
Yeah, that's what. So accordingly to the anesthetician and the cardiology, what they say is if you're taking ecospirin or clopulate, you have clopulate if it is 75 milligram, it's 5 days you have to stop preoperatively. But if it is 150 milligram, you have to stop minimum 7 to 8 days because there's a high risk of bleeding. In the case of ecospirin of 75 milligram, you can just stop it for 48 hours to 72 hours. That's more than enough.
Okay, thank you.
Sir, what about the cyst? If we found a cyst in the X-ray, like if we're doubtful, what will be the next like investigation or in the femur condyle if we find the
You find the cyst.
Yeah, sir. If at all,
No.
if we are doubtful.
Yeah, nothing. Basically, deal the cyst with the bone graft and tell the patient that you might need to rod it. Sometimes, if the cysts are very big and near to medial condyle, you rod it and protect with the brace for at least 3-4 weeks.
So MRI will be the better option after going to.
Yeah, definitely. MRI and CT scan.
Yeah.
Indian कभी तो पैर लिखा इसमें दिखता नहीं लोग दवा लिखते
Right, guys. Right, that looks a wonderful beginning.
Yes, sir.
Of the class. So, as I said, these recorded sessions will be available for you. Go through that and make it. I would advise and take a 100 or 200 page notebook and keep writing with the one blue pen, one red pen, some important points. Don't overestimate your intelligence and don't overestimate your remembrance. Okay, so make a point. These 12 weeks you will get a golden nuggets, which you will not get anywhere else. So all compile them and you will be the winner. I keep telling, fools learn from their own mistakes. Wise people learn from others' mistakes. Stupids never learn. So I want you to be wise men. Okay, we will talk about our mistakes also, as I said, and you be brave and wise with that. Okay. Right.
Thank you.
Yes, sir.
Right, sir. Thank you so much.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir.
Good night.
Thank you.
Thank you, sir. Good night, sir.
Thank you, sir.
Thank you,
Please
sir.
share good article for the next session.
Hello.
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 Sir. Hello.
Sir, please share the good article for the next session.
Hello.
Hello.
Hello, class is done, guys. Just
Yeah,
one.
class is done. So we are finished.
Sir,
Rishi,
please
you
share
can
the
stop the streaming
good-
and stop the Zoom.
Good articles for the.
Any questions you can put up in the chat group now on WhatsApp.
Thank you.
Give us some feedback also on the group. Thanks.